All right. So I'm Devin. I'm one of the R2s in the internal med program here. And today I'll be talking with everyone about HIV pre-exposure prophylaxis. Thank you to Dr. Jihan Budov, my mentor, for guidance on this project. So I do not have any conflicts of interest to disclose for this presentation. And in regards to next slide. Before I get started, I just wanted to gauge the room and see what people experience with prescribing PrEP in their clinic has been. If we may launch the poll for this one, please, Javel. All right, that's awesome. It sounds like there's a lot of people who in the audience have already initiated and continued PrEP for the patients in their clinic. So the goal of the talk today is to introduce residents to the skills needed to prescribe PrEP in their primary care continuity clinics. And for the people who's already been prescribing PrEP, then introducing a little bit more nuance into the practice. So our objectives for the talk today is to recognize the disproportionate burden of HIV incidence on minority populations, evaluate patient risk factors and assess who should be counseled for PrEP, list options available for PrEP, list options in oral PrEP initiation and continuation, identify initial steps in management of PrEP failure, and recognize considerations in using PrEP for patients on hormonal gender-affirming therapy. All right, there's so many topics in HIV medicines to cover, but unfortunately, the things that we won't be able to get to cover today, we won't be able to talk about cabotegravir PrEP initiation and monitoring, nor would we be able to talk in full about HIV post-exposure prophylaxis, and we won't be able to cover molecular biology of HIV and how the mechanism of action of these medications work. Highly encourage you to explore the HIV medicine elective to learn more about these topics. There's also a free website, the National HIV Curriculum, for which then you can also have exposure and learning about these topics through modules. The talk today will be based on information from the CDC PrEP guidelines, and it's also available as a PDF for clinicians to download off the CDC website. So just starting to talk about what is PrEP. So PrEP is a medication used in advance of an exposure to prevent acquisition of HIV. And currently there are 3 available options for PrEP. Truvada and Descovy exist as tablet formulations. These are just 1 tablet once a day. So for Truvada, it contains emtricitabine 200 milligrams and tenofovir disoproxil fumarate or 300 milligrams. The abbreviations that we use would be F for emtricitabine and then TDF for the tenofovir. And then the newer alternative is Descovy. It's emtricitabine with tenofovir alafenamide, also abbreviated as TAF. Both of these regimens are 1 pill once daily. And then newer on the market, there's cabotegravir, which is an injectable medication given once every 2 months in the clinic. So just starting to talk about why PrEP, like why is this important? So this is CDC's data based on new HIV diagnoses in the year 2019 in the US. And gay and bisexual men are the population most affected by HIV. In addition, among the gay and bisexual men who received an HIV diagnosis in 2019, racial and ethnic disparities continue to exist, with Black, African American, Hispanic, and Latinx people disproportionately affected by HIV incidence. Geographically, the American South and the US dependent areas also have a higher incidence of HIV in our country. With all that said, HIV is a very preventable condition, and I want to just show you some data about the efficacy of PrEP through these trials that have been performed. So in the Partners PrEP trial, this was a trial performed between several discordant couples. So one of the persons in the couple would be positive for HIV and their partner would be negative. And in this study, 15,000 individuals was randomized to Truvada, which contains emtricitabine and TDF, another 1,500 to TDF alone, and 1,500 to placebo. And the results demonstrated that there is a 90% risk reduction in acquisition of HIV for people who use PrEP and have detectable drug levels of the medicine in their blood. It doesn't give information about how much of PrEP they're using, whether they're using it once every day or not, but whether if there's any detection of medicines in their blood, then they had a 90% risk reduction in acquisition of HIV. The next important trial would be the Iprex trial, at which this was studied for MSM, men who have sex with men, and transgender women populations. 1,200 individuals randomized to Truvada and 1,200 individuals randomized to placebo. And there was a 92% risk reduction for those who had detectable levels of Truvada in their blood. And for CDC's data, it shows that if patients are taking Truvada every day, one pill once daily, this protection goes up to 99% in preventing acquisition of HIV. So I just wanted to now change gears and see what the group would do in this situation. So we have Donnie. He's a healthy 34-year-old man who presents to clinic for an annual checkup. And 3 months ago, he was treated with ceftriaxone for urethral gonorrhea, and he's asymptomatic today. And based on your practice, would you discuss HIV PrEP with this patient? If we could launch the poll. All right, so it looks like from the results, 64% of the group would discuss PrEP with this patient. 30% would discuss if there's time after other health maintenance, and 7% of the group would not discuss PrEP with this patient. So this is CDC's guidelines recommendation on who should be recommended to discuss PrEP with. So anybody with anal or vaginal sex in the last 6 months and any of the following criteria. If they have a partner who has known HIV, especially if the partner has unknown or detectable viral load, or if the patient themselves had a bacterial STI in the last 6 months, or if the patient themselves has inconsistent or no condom use. This is a very low threshold criteria to discuss PrEP with patients, and it demonstrates CDC's confidence in the benefit risk ratio for PrEP in prevention of HIV. So the bottom line is that any sexually active person should be informed about PrEP, and whoever who asks for PrEP should also be given a prescription for it. And for patients who use injection drug use, if they had injected in the past 6 months and shared injection equipment, then they should also be prescribed PrEP as well. If they also request PrEP, they should be given a prescription. So talking about the PrEP options again, just hope to talk with the group about indications and also contraindications for each of the 3 choices that a patient can be given PrEP on. So for Truvada, which is emtricitabine and TDF, it remains the best initial choice. There's a generic formulation available for it. And it's also the only choice that's been studied for patients who are using PrEP for prevention of HIV, in setting of injection drug use, or for people who would like to use on-demand 211 PrEP. We'll talk a little bit more about 211 PrEP on the following slide. And Truvada and Descovy are both approved for co-treatment of chronic hepatitis B. Truvada cannot be used if a patient's estimated creatinine clearance is less than 60. For Descovy, there's more of a lenient room and can be used as long as the creatinine clearance is greater than 30. However, Descovy was not studied for people who have receptive vaginal sex and not studied for people who use injection drugs. Lastly, the newer option, cabotegravir, is available and it does not have a renal function requirement. So anybody can, regardless of their renal function, would be eligible to use cabotegravir. And it remains the only option for people who have an estimated creatinine clearance of less than 30. It's also a preferred option if a person does not want to use an oral medication or whether their social circumstances prevent them to conveniently or safely use a pill bottle of Truvada in their home. It would be an injection in clinic of cabotegravir every 2 months. So just wanted to share about 211 PrEP. It's an alternative way to taking PrEP. While we usually recommend patients to take PrEP once daily, there is another way to take PrEP that is centered around a sexual encounter. And that's what 211 PrEP or on-demand PrEP is for. So 2 hours before, at least 2 hours before sexual intercourse, then a person would take 2 tablets. And then 24 hours after the first doses that they took, then they would take 1 tablet, and then 1 last tablet another 24 hours after that. If the person continues to have sex after the first initial 24 hours, then they would take a pill every single 24 hours. And then after they stop having sex, then they would then take 2 more pills. And that's because there would be a time period of 24 hours between the last pill and the second to the last pill. Kind of confusing. And usually when I do explain this to patients in clinic, I pull up a diagram on the computer and make sure to just go through the diagram with the patient. Talking a little bit more about on-demand 211 PrEP, it's based on 2 studies, Iprex and Prevenir. And the average, these studies were studied with men who have sex with men and only with Truvada. So there's no data with Descovy for PrEP, for 211 PrEP, I mean. So 211 PrEP can only be recommended with Truvada. Since the studies were not conducted for people who have receptive vaginal intercourse, it's also a leap of faith to say that 211 PrEP can be used for that population. So we usually only recommend 211 PrEP for MSM populations. Another caveat is that the average person in the Iprex study used around 15 doses of Truvada a month. And as opposed to daily PrEP, that's 28 doses of Truvada a month. So it's important to recognize that these studies were conducted in a population that had a relatively high baseline level of Truvada in their blood anyway. And lastly, on-demand PrEP is not recommended for people who use tenofovir treatment for hepatitis B, as that would require daily use of the medication. Neither is on-demand PrEP recommended for people using gender-affirming hormones, and it's not studied for people who use IV recreational drugs. In general, 211 PrEP is there's quite a few stipulations to it, and it's not a very generalizable way to use the medication. And typically, I don't recommend my patients to use on-demand PrEP in clinic, but I do want them to be aware of it as an option in case their peers are using it. So I just wanted to gauge the room and see what you all would do in this situation. So we have Jerry. He's a 56-year-old man with CKD secondary to diabetes, and he comes today to talk about PrEP. He has 3 partners, He does not use condoms, and his medications include insulin glargine, losartan, and atorvastatin. 2 weeks ago, he had an estimated creatinine clearance of 15. What would be the most appropriate choice of PrEP for him? Truvada, Descovy, cabotegravir, or Truvada with dose reduction to 1/2 tablet a day? Or can he not use any of these options?
While folks are answering that poll, Devin, there's a few questions kind of coming up in the chat.
Yeah.
I think namely there's discussion of the drug assistance program in the state of Washington for PrEP.
Yeah. Ryan White funded HIV clinics do have some available resources, including EIP, financial assistance for PrEP. Madison Clinic does participate in that. Additionally, Gilead also has a fee assistance program. That's my understanding.
I can chime in as well. The Washington State has a drug assistance program for PrEP that literally you can just apply online for, and that should cover the cost as well.
In addition, any other questions that the group has?
Gina was wondering if you have a good go-to place for patient-facing resources on PrEP and on-demand PrEP.
Yeah, the CDC website has a patient-centered portal as well to talk about PrEP. They also have a video created for patients to understand what PrEP is. All right, so the correct answer is cabotegravir and C. And the reason is because the patient's renal function is less than 30. They're actually contraindicated to use both Truvada and Descovy. There's unfortunately no split dosing of Truvada into half pills, or it has to be taken as a whole pill at the same at each of the time it's taken. So now just wanted to talk about initiating PrEP in clinic. So many times patients come into clinic and would like to initiate PrEP on the same day. And the decision to start same day PrEP hinges primarily on the patient's history. So taking a thorough medical history is important. You would want to confirm whether the patient has any history of CKD or hepatitis, as that would influence what PrEP options you use. And then also whether they have osteoporosis and hyperlipidemia, and this relates to some of the side effects of oral PrEP. And then also getting a detailed substance use history, including history of injection drugs, alcohol, tobacco, and other recreational drugs. For sexual history, ask about the patient's partners, the number of partners, the partner's HIV statuses, the types of intercourse that they have, whether the patient used condoms, what they use for contraception, any history of STIs, and then intimate partner violence screen. And then for your review of systems, ask about signs and symptoms of acute HIV, which we'll cover in the next slide. And also obtain immunization records for human papillomavirus vaccine, hepatitis A and B. And for MSM populations, also confirm whether the person has received meningococcal and monkeypox vaccines. So for acute HIV, the signs and symptoms include constitutional symptoms like fevers, night sweats, chills, and fatigue, and also some general non-specific symptoms like lymphadenopathy, mouth ulcers, rash, and muscle aches. In all, it just looks like any other viral infection. If a patient does have signs and symptoms of acute HIV, then they should not be started on same-day PrEP in clinic. And it's also recommended that you test them for HIV with both a HIV fourth generation antigen antibody test, as well as a viral load. The next question that you want to ask your patient before just starting PrEP is ask them when was the last time they had condomless intercourse with a partner of unknown HIV status. And we split this up into 3 buckets, whether that last exposure was less than 72 hours ago, between 72 hours and 21 days ago, or over 21 days ago. So if the last condomless intercourse was less than 72 hours ago, then the patient should not be prescribed PrEP. And instead, they should be getting a 28-day course of post-exposure prophylaxis. And if your clinic does not provide post-exposure prophylaxis, then you can give them a 5-day starter course of Truvada, 1 tablet a day, and dolutegravir, 1 tablet a day, and submit an urgent referral to the Madison Clinic for counseling on post-exposure prophylaxis. If the last intercourse was greater than 72 hours but less than 21 days ago, then you would want to obtain an HIV 4th generation antigen antibody test and a viral load in the initial visit. And the reason is because it takes around 21 days or so for the antigen antibody test to become positive. But the viral load is more sensitive for the window period in this window period. So you would want to get both to detect HIV. If they do not have any signs and symptoms of acute HIV, you can start them on PrEP the same day and then follow up those results closely. And lastly, if their last condomless intercourse was greater than 21 days ago, you can just get the antigen antibody testing and start PrEP if there's no signs and symptoms of HIV. The question is, what if there is signs and symptoms of acute HIV? So you would get the viral load and the antigen antibody testing, and then we'll talk in a later slide about what to do if the results become positive. The next set of the initial history is checking the patient's medication list. So here are some common medications that patients may ask you about when you start PrEP. So it does not interact, PrEP does not interact with buprenorphine nor methadone, and neither TDF nor TAF, like the active ingredients in Truvada and Descovy, neither of them interferes with oral contraceptives. So no dosage adjustments are necessary. For people taking feminizing hormones for gender-affirming therapy, such as spironolactone and estrogen, there is some studies that links lower tenofovir levels in the rectal tissue. And the flip side, the TDF does not affect hormones levels. So the patients don't need to change the doses of the hormones that they take. And with people using gender affirming therapy, adherence become quite important just because it's unknown whether the decrease in the tenofovir concentrations in the rectal tissue would affect PrEP effectiveness. So adherence becomes very important. There's no data for TAF, which is in Descovy. There's no data for Descovy for people who use gender-affirming hormones. Lastly, for people who use acyclovir or Valtrex, the concentrations of these medications and with TDF can be increased when used together. So it's important to monitor for dose-related toxicities when people are using Truvada with Valtrex. And there's no guidance from the CDC PrEP guidelines on how to monitor for BMP in this interaction. It's up to the clinician judgment. And then the next slide is a busy slide about the initial labs that should be obtained, as well as routine repeat labs that should be obtained for people who are on PrEP. So we're going to go through this column by column, starting first with the which labs should be obtained on the initial study. So you want to start by obtaining the HIV test, including an antigen antibody and a viral load if a patient, depending on the patient situation that we talked about earlier. And at the initial visit, you also want to obtain a BMP to get a baseline renal function, initial STI testing, including syphilis, gonorrhea, chlamydia, And for people having receptive vaginal intercourse, trichomonas testing. For people you plan to start them on Descovy, you want to obtain a lipid panel. And this is related to the side effect, which we'll talk about for Descovy. You would also want to obtain an initial hepatitis B battery in the initial visit, and to make sure whether a patient already has immunity to hepatitis B or not. And if they do not, then you would vaccinate them for hepatitis B. And lastly, for men who have sex with men, transgender women, and people with injection drug use, you would also want to obtain a hepatitis C antibody with a reflex PCR. In terms of repeat monitoring, every 3 months, you would have the patient come back for an HIV test and STI screening. And the frequency to do BMP screening for renal function, it depends on a couple things. When you start, it depends on when the time that the PrEP was started on the patient, what their age and baseline renal function was. So if a patient is age greater than 50 with the estimated creatinine clearance of less than 90 at the time of PrEP initiation, then you would obtain a BMP every 6 months. But if the patient is less than age 50 and has normal renal function greater than 90, when you start PrEP, then they can get a BMP every year. Lastly, you would also want to obtain a lipid panel and a hepatitis C testing every year. At the time a person stops PrEP, they should also get a HIV test, a BMP, and an STI screen at the time of stopping PrEP. Can you all see the top row of the slide? It's not blocked from view. Okay. All right. So now, saying that if you have decided that this patient is safe to start PrEP on the same day, there are several things that you want to counsel the patient about when starting PrEP. And first, it's about side effects. So in terms of startup side effects for Truvada, it includes headache and abdominal pain. And for Descovy, it's diarrhea, nausea, and abdominal pain. It's actually a very similar side effect profile. Many clinicians prescribe several doses of Zofran for the patients to take home. Usually these side effects last only around a week or so, and after that, most patients do really well. In terms of long-term side effects, Truvada is associated with decreased bone mineral density. Usually we see this side effect more in patients who are using Truvada as part of a multi-drug regimen to treat HIV, and they're on Truvada for many years. Usually for people on PrEP, it's a younger population and also a population who do not stay on PrEP forever. So the bone mineral density issue is a little bit less important. There's also a small risk of weight loss with Truvada and a very small risk of kidney injury, which can look like AKI, CKD, and Fanconi syndrome. For Descovy, the long-term side effect is increased serum triglycerides, and that's why we get a baseline lipid panel and one every year for patients on Descovy. And the next thing to counsel the patient about is how long they should use condoms for when they start PrEP. So it takes a period of time for PrEP to reach, for the tenofovir to reach protective levels in the tissues. And in vaginal tissues, it takes longer to accumulate than rectal tissues. So for patients who are using PrEP for receptive vaginal intercourse, they should be counseled to use condoms for at least 21 days after starting PrEP. And patients who have the other types of sex, including any insertive intercourse or receptive anal sex, then they should be counseled to use condoms for at least 7 days. Next part is to talk to your patient about taking the medication once daily. And it might be helpful for them to set a daily alarm at the same time every day, or couple taking PrEP with a daily routine like brushing teeth. A pill box can also be helpful. If medications are missed, then the patient may take it whenever they remember, and at the following day, take the next dose at their typical time. Adherence is very important. with patients taking PrEP, but there is actually some forgiveness if a dose or two is forgotten. So according to the CDC guidelines, if a patient uses 7 doses a week, so 1 tablet a day, then it's 99% effective. If a patient uses 4 doses per week, then it's 96% effective. And if a patient uses 2 doses per week, then it's 76% effective. And there is some level of forgiveness in this. Typically, I don't tell my patients this in clinic, but it's important for clinicians to know that it's not the end of the world if a patient missed a couple of doses of Truvada. With that said, patients who have receptive vaginal intercourse, the tenofovir does not accumulate as readily in vaginal tissue. So the forgiveness for people who have receptive vaginal intercourse, if they miss doses, there's a little bit less forgiveness with that. Next is talking to your patient about when they should come back for STI testing. So it's recommended that they come back every 3 months, or if they ever have a new partner. And also advise patients that PrEP really only protects against HIV and doesn't protect against herpes, syphilis, gonorrhea, chlamydia, trichomonas, monkeypox. Condoms are still very recommended. So hope to now see the group about this next question. We have Vera. She's a 30-year-old woman who would like to initiate PrEP today. In the last 6 months, she's had 3 partners with whom she has receptive vaginal intercourse. She uses condoms and OCPs for birth control, and she would like to reduce her risk of contracting HIV. What would be the most appropriate initial medication for her? Would it be Truvada, Descovy, cabotegravir? Does her OCP need to be stopped prior to starting PrEP, or does she not qualify for PrEP at all?
Devin, while we're waiting for people to answer, I may have put the wrong formulation in my question, but I was curious if anybody do we know why the particular formulation of tenofovir raises triglycerides, like why one of them does and one of them doesn't?
That's a really good question. I think I do not know the answer to that question, why the alafenamide formulation increases triglycerides, whereas the TDF formulation does not. That's a really good question. I wish I knew the answer.
Okay, interesting. Yeah, I think I accidentally wrote, so it's TAF that elevates, okay.
Yeah, TAF elevates serum triglycerides in the long term. All right, let's see what the group thinks. Yeah, so the correct answer for best initial choice is entrocitabine with TDF or Truvada. And cabotegravir is actually another option for a patient who have receptive vaginal intercourse. However, Truvada is the best choice, given that there's a generic formulation available and many clinics have not been set up to give cabotegravir yet. With that said, it's also about shared decision-making with patients about whether they would like to use an oral medication or an injection medication every 2 months. Descovy has not been studied for patients having receptive vaginal intercourse and cannot be recommended in that situation. OCPs do not need to be stopped prior to starting PrEP. And the last answer choice, E, some people might think that she does not qualify for PrEP given that she uses condoms consistently, and I didn't give you any information about STIs. However, as long as the patient asks for it, they should be given PrEP. So now we'll talk about PrEP continuation. So every 3 months, you'll have the patient come back for getting more history about if they have any updates to their sexual history and substance use history. Ask them about any side effects and to the PrEP and how their adherence have been. Assess for signs and symptoms of acute HIV. Obtain routine labs, including an HIV and STI testing. If your clinic participates, provide harm reduction kits, including sterile needles and syringes, and provide referral and treatment for substance use. Usually a 3-month supply of PrEP is given at a time to coincide with the time that the patient comes back for repeat labs and STI testing. If a patient wants to discontinue PrEP, it would be good to ask them why. Is it because they are tired of using an oral medication? Is it because it's not safe to use a pill and showing Truvada on the label? Then perhaps they might benefit from transitioning to cabotegravir. If a patient discontinues PrEP, it's also important to talk to them about where they can get post-exposure prophylaxis in the community if they were ever exposed to HIV. And lastly, obtain an HIV and STI test at the time of discontinuation from PrEP. Once PrEP is stopped, protection wanes over 7 to 10 days. There's no side effects from abrupt discontinuation of Truvada and Descovy. However, if a patient has chronic Hep B, ideally, they discuss with the specialist before stopping PrEP, because withdrawing tenofovir can lead to fulminant Hep B reactivation. For PrEP failure, usually biomedical failures are very rare. Usually PrEP fails if it's not taken. So if the patient is not adherent, or if they have lost medication access, if they never started PrEP in the first place and was just contemplating, or if they discontinued PrEP, these are biggest risk factors for PrEP failure. Biomedical failures are very rare. It's 99% effective if it's taken once daily. What happens if there's an ambiguous HIV test result while a patient's on PrEP? So you want to kind of gauge them about their recent adherence. Have they been taking the medication? And if they have, then it's unlikely that, make it less likely that they have a true HIV positive test. However, you do want to talk to them about signs and symptoms of acute HIV and see if they have any of those. You would repeat an HIV test with both the antigen antibody and the viral load to confirm whether this is a true positive. At this point, also advise to seek resources, including an urgent referral to Madison Clinic, or call the National Clinician Consultation PrEP line, who there's available personnel to ask any questions on PrEP about. If the patient does have a confirmed HIV positive diagnosis while on PrEP, oral PrEP, then you want to provide an urgent referral to Madison Clinic for them, and then call the National Clinician PrEP line in advance and talk about what the patient should be doing. You want to obtain a HIV viral load, a genotypic resistance assay to test for whether the patient has a strain of HIV that's resistant to HIV medications. Also obtain a CD4 count and a CBC as well. If the patient cannot be scheduled with an HIV specialist within a week, then start the following medications in addition to Descovy or Truvada. So you will want to start dolutegravir 1 tablet once daily, and darunavir cobicistat or Prescobix 1 tablet once daily. And what you're doing essentially is treating HIV with a multi-medication regimen. And Truvada and Descovy does form a part of HIV treatment. So you would just add these additional medications on top of them, on top of Truvada or Descovy, and that makes a complete HIV treatment regimen. We have been talking throughout this presentation about people who use PrEP and gender-affirming hormones at the same time, and I just wanted to summarize it, the teaching on the slide here. So high-dose feminizing hormones is linked to decreased levels of tenofovir in rectal tissue, but it's unclear how much this affects PrEP effectiveness. For this reason, adherence is especially important for people who use PrEP and gender-affirming hormones at the same time. And 211 PrEP, which is intermittent dosing, is not recommended for patients taking gender-affirming hormones. Conversely, PrEP does not affect the hormones concentrations, so the patient does not need to change the level of the hormones that they take. I want to just end by summarizing some key teaching points for the group. So any sexually active person should be informed about PrEP. PrEP options include Truvada, Descovy, and cabotegravir. Truvada remains the best initial choice for people with normal renal function, and patients on PrEP should be checked in around every 3 months or so to talk about adherence and obtain repeat labs and STI testing. And the lack of adherence is the main risk factor for PrEP failure. thank you everyone for your attention for the talk. I just wanted to leave some slides for resources, including the link to the CDC PrEP guidelines for clinicians. And then also an up-to-date article for PrEP, which is a good read, quick read. My goal was to hopefully empower you all to prescribe PrEP in your continuity clinics. And thank you all for your attention.
Awesome. Thanks, Devin. That was great. Looking through the chat, there was a little discussion of what does the F stand for in TAF and TDF, but I think I don't see any other questions right now. We've got a few minutes if folks have other questions for Devin before we wrap things up.
Yeah, so the abbreviation for F that I was using for this presentation was to stand for emtricitabine. Let me share my screen quickly again. I could have been a little bit more clear while talking about this. And usually HIV medications are abbreviated, given that they're usually long names and hard to appreciate. So emtricitabine is usually abbreviated as F or FTC. So Truvada would be FTDF and Descovy would be FTAF.
Where's the F in emtricitabine? Can you tell that to me?
It's from the chemical name. It's a fluorinated derivative of one of the other antivirals. So that's all.
So F for fluorine, it sounds like.
That's I appreciate that thoughtful explanation, but I'm still not satisfied.
Kevin says the Lamivudine is 3TC, so please explain that to me.
Yeah, all these abbreviations are really interesting.
Awesome.
Devin, are you generally prescribing, like if somebody says that they just want to do 211, like a full month's supply each month, or how are you prescribing that?
Yeah, if a patient comes to me to talk about 211 PrEP, I would actually really kind of dig deep and talk to them about what their usual exposures are, and truly whether like how often they're having exposures. Because we were talking a little bit earlier about the 211 study, and with the Iprex study, on average, the participants were using 15 pills per month. So doing the math, 15 divided by 4, people were having a sexual exposure once every week or so. And this kind of predicates a baseline level of tenofovir in someone's blood. With these studies done in Iprex and Prevenir, it's important to make sure, how do I say it? There's a concern that if a patient is really only having very infrequent sex, are they actually achieving the same level of tenofovir in their blood as the average participant in these studies? It's unclear. And for that reason, I would actually really dive really deep into the history with this patient and talk to them about what their risk factors are. And also talking about like the things about 211 PrEP is that the startup syndrome can happen each time they restart PrEP, meaning that they might have the GI distress, the nausea, and that's another reason why 211 PrEP is not a very generalizable way of doing PrEP. So it'll be a benefit risk discussion and talking about the limitations in the studies that studied on-demand PrEP in the first place, if that makes sense. Oh, and your question was whether you would give them the full 30-day supply, and the answer is yes. You would still want to give them a full 30-day supply, especially if they're having very frequent episodes of sexual encounter. Then you want them to be protected throughout the whole month.
There's a few other questions in the chat, Devin. I don't know if you can see them. Aya asks, for people with one partner HIV positive on therapy with no detected viral load for 6 months, my understanding is they don't need to be on PrEP. Is this accurate? I find it tricky because you're relying on the partner.
Correct. So U equals U is an acronym that we use for undetectable equals to untransmissible. And for people who have undetectable viral loads, they would not be able to transmit HIV through sexual exposure to their partners. However, if the patient who desires PrEP feels safer, that even if their like whoever wants PrEP can get PrEP. So if the patient feels like they would feel safer starting PrEP, even though their partner is undetectable, I would still give them a prescription for PrEP. And is there another question on that?
Just a lot of comments about organic chemistry as it pertains to tenofovir and lamivudine. I saw Kevin commented that the Madison attendings have taught me in general not to start PrEP as 2-in-1, but to do it after a successful first few months of adherence. Talking about prescribing a 90-day supply if you can.
Do you mind if I share some experience with discordant partners, one undetectable, and like the negative partner wanting PrEP anyways? Sorry, that was complicated to explain, but I guess in my experience, like I try to destigmatize, like, because really U equals U is like a firm recommendation, and it can be a little stigmatizing to like to kind of medically like agree with the patient that they should be on PrEP, even though they really don't need to be. But that is a very complicated interaction, and I feel like the best way to do it is to, start them on PrEP, as Devin said, but then as you get to know them and, get to know their partner, get to know like what their relationship is like, you can build trust and continue to counsel on U equals U. And I've seen people come off of PrEP after like developing some more comfortability with the idea and just establishing a good relationship. And like going over the studies can be helpful too, not like in depth, but like the fact that these were tens of thousands of sexual encounters of serodiscordant couples and not a single transmission of HIV, like that is like, it is not just like a soft recommendation. It is like the CDC like fully endorses U equals U.
Awesome. Thanks, Kevin. Great. Well, thanks everybody. Thanks so much to our speakers today for a great first academic half day of the year. John Cho wrote this in the comments, but just as a reminder, if you are ever wanting to look back at these things like the slides or handouts for reference, you can find them with the links that Lindsay sent out yesterday. We also have a YouTube page where all of these get recorded, where you can go back and look at talks for your reference.